Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We are in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience. Naruvi
Hello, and welcome to a new edition of the Hindu Wellness Series presented by Naruvi Hospitals, Vellore. Today's webinar will throw light on neurospine surgery, evolution of comprehensive care. Till about 2 decades ago, the neurosurgeons were the torchbearers and primarily responsible for surgeries of the spinal cord. But over the years, spine surgery evolved and saw two types of surgeons, the neurosurgeons and the orthosurgeons, collaborating on the typical spine operations, tumor excisions, when people report head, neck, or back pain. Though each have their respective specialization in brain, spinal cord, nerves, bones, and joints, what necessitated teaming up of the two was deciding on the right type of surgery and a favorable outcome for the patient. To talk about the benefits of the neurospine surgery, we have a panel of experts from Naruvi Hospitals in Vellore. And we will start the session with one of the senior-most neurosurgeons in the country. Professor Matthew Jacob Chandy is the senior consultant and advisor in neurosurgery at Naruvi Hospitals, Vellore. He qualified from the Christian Medical College, Vellore, and rose to become the professor and head of department. He has trained more than 50 neurosurgeons. He has numerous publications and chapters in textbooks. He has been the past secretary and president of the Neurological Society of India. Professor Chandy is a recipient of the Eminent Surgeon Sanghamlal Award given by the National Academy of Medical Sciences. He will now introduce to us the interesting topic of a new synergy between the neurosurgeons and orthopedic surgeons and how it helps to improve the comprehensive healthcare system. So welcome, and over to you, Dr. Chandy.
Good morning. At the outset, I must say a few words of introduction of the development of spine surgery throughout the world and, of course, in India. By and large, the evolution of spine surgery started with the neurosurgeons doing spine surgery. However, there have been, and there are certain countries where spine surgery first started with the orthopedic surgeons. The orthopedic surgeons started spine surgery in India in the early 90s and then have rapidly evolved into a well-structured group of people who now have their own society, the Ortho Spine Society. Following this, the neurosurgeons who started spine surgery also started their own society called the Neuro-Spine Society. However, as this may be, the most important thing is that the patient should benefit from both these groups and their special skills. The orthopedic spine group focus on spine stability, and of course they use specialized tools and hardware to achieve this. That is the focus. The neurospine surgeon focuses on neurological evaluation and protection of neural tissue. And as you know, the neural tissue below the brain is protected by the spine. Now, it is very important to note that both these foci are very important for the patient, equally important. And therefore, synergy between these two thought processes, we feel, will eventually give the ideal outcome for the patient. Now, bringing these two groups together to look after one patient is only an administrative issue. And in Naruvi, under the able leadership of the head of neurosurgery, it has been possible to bring both these groups together and put their minds together for looking after patients with complex spine problems. So I think this synergy is something that we are going to talk about. The synergy between the orthopedic spine surgeon who has his own strengths and the synergy with the neurosurgery, neurospine surgeon who have their own innate strengths. So with this introduction, we will go to the presentations. Thank you very much.
Thank you, Dr. Chande. And we have indeed one ortho surgeon and one neurospine surgeon. So we'll first move on to Dr. Bhagyaraj. After completing his MBBS from Kilpauk Medical College, Chennai, Dr. D. Bhagyaraj did his MS in ortho from Delhi's All India Institute of Medical Sciences and also completed 2 fellowships in spine surgery from Bhagwan Mahavir Jain Hospital, Bengaluru, and Stuttgart Spine Center, Germany. Dr. Bhagyaraj began his professional career in Chennai Medical College Hospital and Research Center, Trichy, and also worked at Dhanalakshmi Srinivasan Medical College, Perambalur, and Apollo KH Hospital, Vellore, before joining the Naruvi hospitals in 2020, where he is now a consultant spine surgeon. He has also been a guest lecturer for multiple continuing medical education programs. So in the next few minutes, you will hear him talk on the role of spine surgeon in the neurospine surgery. Welcome, Dr. Bhagyaraj.
I think Dr. Pubesh talk is first, ma'am, I think.
Okay, whoever wishes to, do you want to first go, Dr. Pupesh? You're not audible. Or you can proceed, Dr. Bhagyaraj. This one and the same thing.
Okay.
Since I've already introduced you, you could proceed with your
Yes.
presentation.
Okay. Just. Good morning, all. I'm Dr. Bhagyaraj, working as a consultant spine surgeon in Naruvi Hospital, along with in the Department of Neuro-Spine Surgery. So, as orthopedicians, we are in our training period trained in identifying the problems related to bone and joints and the diseases of bone, like fracture, deformity, or ligament injury. So, depending on the problem, we will decide whether the patient needs surgery or whether surgery or non-operative treatment. If surgery is required, how to fix a bone. So in spine surgery, we apply the same things. We identify the bone and joint problems related to disease of spinal bone, that is called vertebra. The neurostructures are protected by the bones. So we need both, as Matthew Chandis has said, we need both for the proper functioning of a human body. So if it is a fracture, if it is unstable like this, we need to fix it. And again, when the bone is very weak and it has fractured, we will fix it with cement. And if there is a weak bone because of infection, we will stabilize and we will give antibiotics. The infection will heal. Till then, we need to stabilize the bone to protect the neural elements. So when the spine is curved and it is causing balance issues to a patient, we'll try to correct it by doing some procedures called osteotomy to the spines. And when there is an issue where the spine meets the pelvis, because we routinely do pelvic surgery, so during our ortho practice, it will be easy for us to combine spine surgeries with the pelvic bone surgeries. In the same way as neurosurgeons do routine brain surgeries, problem happening in the junction of head and neck, the neurosurgeons may handle better. So in spine surgery, it's safe. Spine surgery in Naruvi, we follow some procedures to be a safe spine surgery. So there are we have spine endoscopy and microscopy, which provides us magnification and proper illumination. So we can see the structures very clearly. It minimizes the chances of accident injury to the nerves. And we can monitor, we have a neuro monitoring unit. It can monitor the functioning of the neural tissues while doing the surgery, function of the spinal cord, whether the connectivity is intact. It is just like a ECG or pulse oximeter, which monitors our oxygen level in the blood or heart function while. So the same way we have a neuro monitoring. So the chances of neural injury during surgery is very less. And we have intraoperative navigation. So we can visualize the screw. If we are applying the screw or any implant, we can visualize the trajectory of the screws and avoid inherent injury to the neural structures by using this. And fourth most important thing, what I think is we work as a team. Ortho, spine surgeon, neuro spine surgeon, and neurologist also. Most of the complex cases we discuss together. Most of the patient will not know what is happening behind, but whenever there is a difficult case or complex case, we discuss as a team and we'll plan. So there are chances for mishap is very less. Thank you.
Thank you, Dr. Bhagiraj. So our final speaker for the webinar is Dr. P. Bhupesh. He did his MBBS from Madras Medical College and completed DNB in neurosurgery in 2015. Trained in robot-assisted surgery at Claudio Munari Center for Epilepsy and Parkinson's Surgery in Milan, Italy, Dr. Bhupesh currently works as a neurosurgeon at Naruvi Hospitals, Vellore. A life member of the Neurological Society of India, his areas of interest are surgery for brain and spine tumors, robot-assisted surgery, epilepsy surgery, and cervical disc replacement surgery. His talk on role of neurosurgeon in the Neuro-Spine synergy is a presentation of an interesting study of a major case that highlights the teamwork between neuro and orthosurgeons. Welcome, Dr. Bhupesh.
Welcome. Okay. Can you see the slides?
Yes, sir.
I'm starting the presentation. Good morning to all. Myself, Dr. Bhupesh, working in Naruvi Hospitals as consultant neurosurgeon. I thank the Naruvi management and the Hindu group for giving me this opportunity. Today, we are in an era where we are dealing with complex situations like the climate change. But humans can't always be involved. So artificial intelligence is used to find solutions to these kind of problems. Similarly, in medicine, we are a tertiary care center and we are always dealing with complex cases like the one which I'm going to present. We got a solution by synergy. Team of surgeons with different specialties and different skill sets, putting their energy and expertise for a problem. I think this is an evolutionary process to get the best outcome for a patient who has a complex problem. Having this presentation made for public, I have included relevant photos for your understanding. Please excuse the text content. Here we have a 65-year-old lady brought by a wheelchair to our clinic. She has not been able to walk for the last 1 year. She has burning sensation and weakness of the left side of the body for the last 3 years. She was clinically evaluated. While checking her, we could locate the problem, which is located in the neck region, which is probably compressing the spinal cord, and that is why she is not able to walk. And the problem is on the left side. That is why she has the weakness and burning sensation on the left side. You can see that this is an MRI of the neck of this patient, and the red shaded area of this area is the tumor sitting in the spinal canal, and this tumor is seen to be going out to the neck from the spinal cord. The tumor is arising from the spinal nerve root, which supplies her left arm. This is another perspective in the MRI, which shows along the length of the tumor size is around 4.5 centimeter, and you can see that we can note that we can see that the tumor has been compressed. Tumor is compressing the spinal cord at this level. Hence, she is not able to walk. Now the patient asks me, what next? I have to treat. To treat, I have to set the goals and options for treatment. The goals are to prevent further worsening of the symptoms, get her back to normal life, make her walk, and provide cure. The options of treatment are either wait and watch conservative management versus surgery. Let's see how we took the best decision for this patient. Now wait and watch. When we wait and watch, the tumor is gonna grow, the symptoms will progress, she will become bed bound, there's no way of normal life, there will be no cure. Now, when most of the centers, they would advise biopsy or a partial excision. In this condition, this tumor is not completely excised and the tumor can still grow. So the symptoms will progress and she will become bed bound. There she will not be able to get back to her normal life and there is no cure. She may need repeat surgeries because the tumor will grow. Now the total excision. When we totally excise the tumor, the symptoms will improve because the pressure effect on the spinal cord is relieved. She'll be able to walk and she can lead to a normal life, and there is a complete cure from this condition. By now, we can understand that the biopsy or a partial excision is not a good option, but most of the patients undergo this, which is easy for a single surgeon to manage these kind of cases. Now, how to remove the tumor completely is where the synergy comes into play. We have an integrated neurospine and orthospine unit in the hospital. The surgery can be done in two ways. It can be done in two-stage surgeries or in a single-stage surgeries. When it comes to two-stage surgeries, everything is done twice. And the patient has to undergo two anesthesia, and then the cost will also be doubled, which is understandable here. For a single-stage procedure, we have to deal with the tumor from the back side only, and as the tumor is to be removed from the back side, the neck portion of the tumor can be removed only by removing part of the bone in the back, so that needs to be fixed. The duration of surgery, which could be 8 hours, is a big thing on a single day, and the cost here, despite that, will be lower because it can be done on a single surgery cost, and there is no big complication associated with it. Now, this is the above is the previous image I posted in the start of the presentation, and the second image, the lower one, is the image MRI done after the procedure. You can see that the entire tumor is removed and the spinal cord is free in this location. This is a X-ray after the surgery, where the orthospine comes into the picture. They fix the spine because we have to remove part of the bone on this side because the tumor is going on this side. So this becomes unstable. So the bone will move after the surgery. He came in after we did the procedure to fix the spine. Have we reached the goal? It's a big yes. Yes, she went home on the 5th day after the surgery. She was cured of the disease. There's no further treatment as needed because it is not a cancer. And she will get back to normal life with doing physiotherapy. And she got the best outcome of the lot. What are the red flag signs for spine problem? Only neck and back pain, no need to worry. Neck pain going to the arm or back pain going to the legs, yes, probably you may need some consultations and evaluation for that. If there is a back pain while turning in bed, probably because you have an unstable spine, you might need an evaluation. Senselessness in the hand or foot, any weakness of the hand or legs, imbalance while walking, frequent fall, inability to hold urine can be part of a spine problem which needs to be evaluated. Take home message. Everyone can have neck or back pain. No need to worry as most of these are muscle cramps. Even if the pain goes to the hands or legs and MRI shows a disc prolapse, almost about 90% of the patients will become normal with medical treatment and lifestyle modification. Only the rest 10% may need surgery, and if the symptoms persist with medical treatment for after 3 months. Multiple treatments are there. The best option cannot be the medical treatment always. To achieve cure is difficult. We have a unique integrated system to achieve cure despite the difficulty. And this is the future of medicine, I think. Almost all complex problems can be tackled with synergy. What's more unique at Naruvi? We have the first robot in Tamil Nadu, and we were doing robot guided surgeries since the start of the hospital. We have done up to 10 robotic procedures in the hospital, and we have navigation for the brain also, and navigation of the spine also. And we do intraoperative neurophysiological monitoring to avoid any complications during the surgery. We would know that the patient is going to have a complication after the surgery, after the anesthesia, while doing the surgery. So we can avoid a collateral damage during the surgery. Thank you.
Thank you, Dr. Bhupesh. I would request our participants who have joined this webinar to start posting the questions. The question and answer box has been open. And meanwhile, I would like to ask the panel, well, we have all talked about, I think, more of about the technical part and the technical collaboration of surgeons of different departments. From a strictly patient's point of view, Dr. Bhupesh, you have highlighted the red flags. I mean, what are the symptoms to look out for, perhaps? But there are also many times overlapping, like some of the symptoms which you mentioned. It could be also overlapping with other diseases. And we also generally tend to see that people are perhaps always not so much aware of the symptoms. Even if they're aware, they keep neglecting, they keep postponing a visit to the doctor. So if all of you could briefly highlight or underline this message, like who are the people who should immediately seek attention of neurosurgeons or orthosurgeons, and like who should actually be evaluated for neurospine surgery? I mean, which is that stage when a person should approach the doctor at the right time to avoid any further complications or any other problems. Maybe each of you could give your little bit of inputs. It is basically to underline that message clearly. Who would like to go first?
I can point out.
Yeah. Yes, sir.
Any patient who has a neck pain or back pain, they can meet either of us, neurosurgeon or a spine surgeon. Both are equally efficacious in treating both the conditions commonly.
But can I interrupt you here? How will the patient make that choice?
Depending on the availability of the persons. Not everywhere neurosurgeons, not everywhere spine surgeons are there.
Okay.
Bhakaraj, can you add anything to it from your perspective? Your voice is not. You are mute. Yeah.
In Naruvi, the patient need not worry whether we to see whether neurosurgeon or ortho spine surgeon, because we are working as a team. Who the patient sees, the patient gets the best treatment. Outside, between your availability, they can see whoever is available.
Dr. Chandy, would you like to give your inputs?
Well, I think what I have to say is that a patient can go either to a neurosurgeon or to an orthopedic surgeon, because the best in the field will be able to tackle all the problems. But as I said, in a average sort of circumstance, especially in smaller hospitals, the best way to go forward is when there is synergy between the ortho-spine surgeon, if he is available, or a neurosurgeon, and that both work together for the good of the patient.
So all of you have talked about this synergies. So what exactly or how exactly are the benefits of these two departments teaming up? How are those benefits kind of transferred to the patient?
The benefits are transferred because the skill sets of these two group of surgeons are indeed slightly different. And although a common problem can be managed by both groups equally well, when it comes to a complex problem, since the skill sets are slightly different as described by the case study, you will find that the synergy becomes very much more useful and for the patient, and the outcomes will definitely be better.
So to you both, Dr. Bhupesh and Bhagyarat, since you must be sharing this load of surgeries, so how many surgeries do you do, say, in a day, in a week, or a month? Is there any statistics available?
Yeah, we neurosurgery, pure neurosurgical cases, we would do like around 20 to 30 a month. And in case we have a spine associated with the neurosurgery, any case that comes for spine, we would do it together. That would be depending on the number which comes to us, number which goes to them, depends on that.
No, so is there any statistics available of the last 10 years that so many surgeries have been done?
We in the last 4 years, this hospital has been there for 4 years only. So we've been doing this for almost 50 surgeries or so totally.
Okay, but no, no national statistics. We are only talking
No, we are
about
talking
your
about the
hospital.
hospital. We are working in the hospital, so we can talk about only in the hospital.
No, but you must be also reading up material with the updates.
Yes.
For the CMEs and all. So that's what I'm asking, if there are any figures available.
It's not that.
Or what is the incidence? What is the incidence of say ailments which require neurospine surgery?
That's what I'm telling you. 10% of almost every back pain needs a surgical procedure.
10%.
Yes. So it again depends on the patient's condition and their decision. If they have to go back to their work earlier, they would opt for surgery, despite we can still avoid a surgery. There are situations where we can have to do the surgery whether they are willing or not. It depends on their condition. Suppose if they have a leg weakness, they are not able to walk, they are bedridden, then we have to pitch in whether they like it or not. We have to give them the option. If they still decided they are okay with the bedridden status, then we have to let it go. Sort of.
And how much does this surgery cost? I think you did mention one of your presentations about the cost factor. So since two departments are involved, so does it add to the burden, financial burden of a patient?
No, that's the thing. That's the thing with this integrated department. So when we have two separate specialists involved in a surgery, each specialist is usually paid separately, and each surgery is costing like it's a single surgery for each of the specialties. Now, being an integrated department, the cost remains same as a single surgery. There's no difference between who does what. It is only one surgery, and the cost goes down.
So maybe you could also explain, how you help each other, like you were mentioning in the backroom discussions, how treating a major case, like the neurosurgeon perhaps spends 8 hours to complete a surgery, but it eases the load on the next surgeon coming in, the ortho surgeon coming in to fix it up. So if you could just describe that part, how you help each other, Dr. Bhagyaraj and Dr. Bhupesh, in doing a surgery.
Yes. So I'll
Maybe
give you
Dr.
the answer.
Bhagyaraj, yeah.
Yeah, if my Bakraj can give us, because he would see
Whatever.
us getting exhausted and he has to help us in that. Yes.
So, like same with the discussion, one person cannot keep on talking. So we'll enter whenever they are getting exhausted. Whatever complex case, it's for fun. Just whatever the complex case comes, we sit together and plan the surgery first. What need to be done for the neural structures? What need to be done for the bone structures to stabilize? So in the same way, which one to be done first? If the bone stabilization need to be done first I will go in and stabilize the bone. Then I will hand over the patient to the neurosurgery team. So they will do the tumor work or intradural work. Otherwise, some patients will require first dural work. Then they will go in and everything will be discussed prior to the surgery. So on the day of surgery, we will not have any. So we will be on standby. Sometimes we'll do it together. Sometimes one team will do the first surgery, first part of surgery, then second team will enter. So it depends on the patient condition and what's required for the patient.
Dr. Bhupesh, you would like to add anything to that?
Yes. See, our kind of surgery is neurosurgery is usually like a walk. It's slow and it is steady. It needs more endurance. We are used to operating averagely for 4 to 6 hours or 8 hours. But again, when it comes to a fresher mind at the end of fifth hour or sixth hour, we might not have enough what do you call enough thought process to deal with out of the box thinking will not happen, is not expected to happen on that point of time. Also, since we are dealing with the softer tissues, when it comes to bone, the skill set is little bit different compared to the orthospine surgeons. When it comes to a different skill sets, the orthospine surgeons, they are always dealing with the bone. You can see, you could have noticed Dr. Bakar's presentation showing screws in every slide, which means that he is very much able to tackle situation if that screw or if there's a bone that is not on the size of the screw. Lot of things which are part of the part of the planning. He will be able to tackle then and there. But after a major surgery from the spinal cord, these things can be handled. Yes, not always. It's not impossible, can be handled, but the quality of work may be degradable because of the difference of the skill sets. So when it comes to the best person in the job, give it to the best person in the job rather than doing everything all together as a single person, which may not be beneficial to the patient. It may be beneficial to the hospital or the doctor, but it may not be beneficial to the patient.
Dr. Chandy, I would like to bring you in at this point because you have been among the foremost neurosurgeons of the country. So, and you would have also done lots of surgeries during your span of career so far. So, how did you view this whole synergy? When you saw it coming and the integration of two departments. I mean, personally, also, what kind of load did it take off you?
See, this synergy involves wholehearted support by the neurosurgeon and the orthopedic surgeon, who stop thinking about themselves but start thinking about the patient as the focus. Once you do that, in a complex situation, you sit together and decide about what steps the surgery is going to be and who is going to do what. And both together can sit and discuss with the patient and the patient's relatives as to what is going to happen, and also comfort them and tell them that this is not going to be a double burden for them in any way, and that both are going to use their individual skill sets for the good of the patient. You can discuss that, and then I think complex surgeries can have the most or the best possible outcome. Of course, that is the aim of the synergy.
So do you foresee such synergies in other departments also, as you, Dr. Bhupesh, also mentioned that it is the future of medicine, perhaps?
Do I foresee synergy happening everywhere? It requires a lot of effort. It is a challenge to start with. It requires a lot of effort, and the effort is an administrative effort to not compel, but to show the value of that synergy for the patient and for the doctors, so that you can do your work comfortably and produce the best outcome for the patient. It is an administrative challenge which can, I think, easily be solved throughout the length and breadth of our country.
Thank you. I'll take a few questions. Like, people are wanting to know about the post-surgery treatment. So, like, since two departments are involved, so how, like, questions like what is the length of stay after surgery and what is the diet recommended for surgery? So, if you could just give your inputs.
Can I answer this question? And
yeah, please.
The goal in neurosurgery, as such, in our department, we keep it like 100 hours. Patient comes to the hospital, gets operated, gets home in the 100th hour, 4 days. So that is a standard of care for neurosurgery, and it is even lesser for spine surgery because they are not dealing with the brain straight away. So we deal with the brain. I'm talking about a complex brain surgery, not even a spine surgery. So when it comes to a spine surgery or a brain surgery, the average duration of stay in the hospital is 3 to 4 days because they get admitted 1 day prior to surgery. And about the diet, neither brain or spine surgery requires a change in diet, as everybody thinks, because diet is relevant for abdominal surgeries, general surgeries, because they are getting operated in the stomach. So they may be opting for a liquid diet. Then they have to, if there's a liver problem or something, they have to stop taking some diet. Kidney problem, they have to stop taking some diet. So there are specific diets for, like, called as renal diet, liver diet, and all that. But for brain and spine, they can take anything they are able to take at that point of time. And we usually start the diet 5 hours after the surgery. Like, this patient had a diet 5 hours after surgery. She was awake immediately after surgery. She was made to walk next day in the morning. Since we had it's a long day for her anesthesia, we have to keep her in the ICU for the overnight to see that everything is fine for her till she gets stable. All the drugs which has gone in are getting metabolized, and then she is awake and alert to move out. We would take the drain, the urine drain or any drain, on 24 hours, and then we'll make them walk, go to the room. We'll also suggest them, even in spine surgery, I would suggest them to walk up and down the stairs on day 1, and next day they can go home if they are willing to go home. Because their worry would be, if they are staying in a first floor or second floor, can I climb the stairs, is the question they would ask.
Yes.
I would tell them,
Yes.
please walk in the hospital, make sure that you are comfortable going up and down the stairs, and please get discharged home.
So after discharge, what kind of precautions do you normally recommend?
Bakaras, this is for you. This is the best question for you.
Once patient undergoes surgery, for initial 4 to 6 weeks, the skin healing will take in 2 weeks, but inside the soft tissue, muscles, and bones, it will take around 6 weeks to 3 months to heal better. So for initial 6 weeks, patient is advised not to bend forward or lift weight. It's not like brushing and face washing; those things they can do, but not bending forward completely and lifting something from the floor. That need to be avoided. They should not sit continuously for hours together, 1 hour, 2 hours. But they can walk, or there is no restriction for walking or climbing stairs. So by driving two-wheeler, at least 6 weeks they need to avoid. Four-wheelers they can drive within 2 weeks. And after 6 weeks, usually we'll start the exercise for core muscle strengthening exercise for the spine. So once they start the exercises, after around 2 to 3 months, they will back to normal life. After 3 months, there will not be any restriction in their activities.
So somebody is asking who's 61-year-old and often gets neck pain after sitting for long hours. The pain radiates to shoulder and back of head, sometimes associated visual aura. So what would you advise? Both of you can take it.
Yeah. I'll just start the discussion part. Okay. See
Yes,
this 61-year-old neck pain after sitting, radiating the shoulder. Yes, radiating the shoulder can be a spine problem or a shoulder problem straight away. If they are a diabetic, it can be a shoulder problem more than the spine problem. Being a 61-year-old, they might have a degenerative spine disease, and that is understandable. Now there is a visual aura. Visual aura is not a finding for a spine problem. A visual aura is a finding for a something called as a migraine. So someone who would have a family history of migraine, or father, mother, or siblings would have had a migraine, they might have a migraine gene transmitted to them. Now, what happens is that when there is a migraine gene sitting in them, when there is a degenerative disease like this, when there is a sort of a pain, it usually presents like a migraine will present as a neck pain. Migraine can present the visual aura. I think that we need to evaluate, and then we need to differentiate the two problems from what they are telling. We need to see if the shoulder is a problem. We need to see whether it is a spine is a problem, and is it migraine causing migraine is a finding on the neck problem. We need to differentiate that.
Dr. Bhagiraj?
Nothing more, ma'am. That's what spine problem will never cause a visual related issues. So need to work up the patient.
Okay, while reading the questions and listening to, I was just wondering, since you're again talking about synergy between two departments. So here is one department which handles soft tissues, the other handles bone tissues. One department uses implants, the other doesn't. So how do you, kind of go around or navigate around the little differences that exist between the two departments?
If you first accept that you can't do everything as on your own, there are other people are also equally or more skilled on handling other tissues like dura opening a spinal cord is daily Bhupesh is doing in every surgery. Only if I accidentally injure, I need to suture. That will happen once in a year or once in 6 months. So if I accept that that can be handled by Bhupesh or neurosurgeon very well, then there will not be any issue with ego or sources. If I know the limitations of mine, I know the skills of others, this will not be an issue.
Because I think for a patient, it really doesn't matter or occur once he's inside the OT. He doesn't even know who's touching him and who's doing what. So it is all
Definitely.
left to the doctors to
Yes,
decide
ma'am.
what is best for him or her.
That's why,
So,
ma'am, a
Mr.
patient comes to me. That's why either me or Bhupesh, what depending on the diagnosis, we will decide who will be operating. We will both go in, and if it is a uh, tumor case or dura need to be opened something, I will assist him. If it is a bone related issues need to fix them, he will assist me. So patient need not worry, just they need to come to the Naruvi hospital. We will take care of them.
No, but not
Whichever is
everybody
best for
can
them.
reach Naruvi. No, somebody say up north. How will he reach Naruvi? He may not even be knowing about Naruvi. So
Ah,
the kind
But
of
only very few
services
centers
are
have this option of
exactly.
working together, ma'am.
see, this is a institutional practice rather than a corporate hospital practice. We are trying to bring this practice so that this is a part where we are enlightening this concept. Thing is that in the future, most hospital has to adapt it because it will be forceful to be adapting because we have people who have different set of people like different like you have a patient who have diabetes and hypertension. Would a diabetologist will treat a hypertension? No. Should we? No. In the future, a hypertension treating specialist will be a cardiologist who specialist only doing that. He will not deal with the diabetes. So in that sense, if a complication relevant to the newer therapeutic modalities that is going to come in the future are available, like the monoclonal antibodies or implantation devices, all these will become complex for a common person who doing everything together, like an MD doing a general medicine doing diabetes, hypertension, all that they would be like a primary persons dealing with a patient. When it comes to a complex situations, then they have to diverse it to either a purely practicing person doing that. When it comes to patient who needs two of them, the synergy will have to work in that places. So the future, the hospital functioning should have synergy is what this presentation is all about.
So,
It is to enlighten the
Uday,
public that
sorry.
it is like that.
Right. So Uday Kumar, who's 46 years old and is not a diabetic, has disc bulge at C5 location in his neck. He says he was advised to follow physiotherapy exercises, and even if he does exercise every day, he gets a pain once in a while. So he's seeking your opinion and wants to know how long should he continue the exercise.
The neck
Akash, you
pain,
can answer
he
this.
has only the neck pain, I think. No pain in the arms or
Now, that's
body.
what he mentions. Look, bulge at C5 neck and doing physiotherapy exercises.
Oh, that's what. Only neck pain exercise is doing then fine. But what is his daily activities we need to see whether he's using desktop or mobiles continuously is in same position or is flexing every time. If you some people nowadays use mobile in the hands continuously seeing it. Whatever you do, if you keep on doing whatever exercise, whatever medication you do, if you don't change your lifestyle, then it will not you will not get better. First your desktop, if you are working in a desktop, the desktop should be your eye line level. Then avoid using mobiles continuously for hours together. And if the even after all the modifications, and if some people have a habit of sitting and sleeping in the vehicle or in the chairs, then these are
Bhakiraj is
Maybe you could continue, sir. I think his connection
okay.
is off. Maybe you could talk about the lifestyle changes because all the neck and back
Yes,
problem
yes, yes,
are all so much posture related and all.
yes,
So you
yes,
could throw a
yes.
little light on that.
Yes, yes. Uh, First thing is that they will have a they may be traveling a lot. They may be part traveling a lot because of their job. They may be sitting on a computer because of their job. They may not be able to lose that. There is something called as a workplace ergonomics. It means how they sit in the workplace, how they is the posture that is more important. Along with neck pain, neck physiotherapy, and all that, they might also have to do posture training, posture therapy and training. This would avoid a problem in the neck. See, now when there is a disc bulge on C5 location in the neck, is a very specific problem a patient should be knowing. That is not at all a problem here, because if there is a disc bulge on C5 location which is causing a trouble, there should be a neck pain radiating to the hand. Which side disc bulge, left or right, and parallel to which side hand pain, left or right, will be the one which can be pinpointing to the location. Understand? But people, generally public, they have been shown the MRI, they read the report, and then they come to conclusion that that is the reason. And almost it is so common that they are very specific about the location of the disc bulge. But actually, the situation is that the disc bulge can cause neck pain, and it does not need any major thing other than lifestyle modification. Disc bulge causing a pain radiating to the hand. Left side disc bulge causing left hand pain, right side disc bulge causing right hand pain, needs evaluation and treatment beyond rehabilitation, physiotherapy. So it is like they have to change their lifestyle only. If it is obese, they have to reduce their weight. Not much, 2-3 kgs of their weight would be enough. And posture maintenance is more important. When posture maintenance is getting worse day by day in the population because of the mobile phones.
That was quite heartening to hear.
Yes,
I
it will
mean,
be relatable to public. When I
weight
tell
loss
that, it will
goal,
be
if
very relatable to the
it's
public.
2-3. Yeah. Sankita is asking if there is a trauma case, then how do you decide the surgery at the earliest?
Yes, this is my territory, very close to my territory. Being a neurosurgeon, trauma case, it is a generalized term for a trauma. We decide surgery depending on what is the finding on the clinical condition of the patient and the CT finding. Okay, if they have a bleed, now it's a bleed in the brain. If it is less than inside the brain, if the bleed is more than 30 ml, we operate immediately. Okay, if this more than 50 ml, we have to operate immediately. No way, there's nothing we can do about it anywhere in the brain. Okay, 30 ml is the limit. If less than 30 ml, we can wait. If the clot increases in the next 24 to 48 hours, we advise surgery. Now, outside the brain, there is a bleed. What is the protocol? If the bleeding is 1 centimeter in thick or above, and the brain is pushed because of that to half a centimeter or above, we advise surgery immediately. If it is less than 1 centimeter or less than half a centimeter midline shift, we would wait and watch. Again, there is another bleed which is under the bone and outside the covering of the brain. If that is more than 30 ml at any point of time, we operate. Okay, it's a bland, it's a generalized guideline, but we do operate if there is a bone that is fractured and no, it is sticking into the brain and all that, we operate. That is separate.
So Basavaraja Samshi wants you to focus on the rehabilitation part post neurospine surgery, and he says apart from the regular physiotherapy rehabilitation, also equally important perhaps is social and economic rehabilitation, is his question, apart from the medical treatment.
Bakar,
So would you like to take that?
Audio.
You have to
turn on the audio first.
You have to unmute.
We have a PMR department, physical medicine and rehabilitation department in our hospital. So most of the time after surgery, we will hand over the patient to them. So we will advise. There are trained persons available for rehabilitation of the patients. So they will take care of those rehabilitation things, but they will guide them what is required.
Okay. So I think because we are already
I
1
would
hour
also
up,
like
then
to
we'll
add a
have
few
to.
things on this.
Please.
Because this is something very important. Again, it is not. It has come up because medical treatment alone is not the treatment. The last point I was telling in my presentation is that the patient has to get back to normal life. They have to go back to a normal life is the goal of any treatment. They should never come back to the hospital is the unsaid portion. I don't prefer them coming back for the lifetime to meet me every 6 months or 3 years. No, I don't want that. Now, this is something very important for anybody who goes for a treatment and then they need a rehabilitation. Rehabilitation is a separate specialty onto itself than our specialty. We were acute care treatment specialties. So rehabilitation are chronic care treatment specialties. It is completed. They do a specialized training in PMR. Physical medicine and rehabilitation is the degree, and they do MD PMR after MBBS, and they have subspecialties, sub people working under them. There will be a psychologist, psychiatrist. There will be a vocational therapist. There will be a physiotherapist. There will be a speech therapist. So there will be a group of individuals under which they head the department, which group of individuals are there. So we call that as a rehabilitation PMR department. When a patient completes their medical treatment, they would assess the clinical condition like we assess. They work on the aspect of which part of the patient is lacking and how do they bring it back to normal. And from there, they would advise them till they get back to their normal life. So that's how
Right.
it goes. It's a big thing. It's a big thing. And very few areas, very few hospitals have a full-fledged rehabilitation department. It is a surgery. Success of the surgery. I always tell the patient, the success of the surgery is not in the operation.
Depends.
It's in the completion of the rehabilitation. Otherwise, they should never come back with the same pain again.
Right. So I think on that note, we'll wind up the program. And as we always talk for every disease, I think every individual has to realize that lifestyle changes are important. And also, I guess that, I mean, we really don't have to worry about each spinal problem ending in a surgery. So, Dr. Matthew, I didn't see you for most of the time on the screen, so I thought you were not there and I didn't direct any question to you. My apologies. And thank you for being part of the panel. Thank you, Dr. Bhupesh and Dr. Bhagyaraj, for giving your inputs on the topic. So we'll bring down the, wind up this program. And today's webinar on Neurospine surgery, evolution of comprehensive care under the Hindu Wellness series was presented by Naruvi Hospitals, Vellore. Thank you all.
Thank you all.
Thank you.